recognizes the disease, there was an exponential improvement in the epidemiology and the guidelines in the update, and that make a huge difference. Nowadays, we have a lot of updates and guidelines for trauma. And we're going to know about it, inshallah, in this session. So it's my pleasure to introduce my brother, Dr. Hani Al-Saidi. He's my best friend, and he's a consultant of general surgery and thoracic surgery, his section of thoracic surgery, and he is a former RTB director of general surgery at King Abdullah Medical Complex.
Thank you very much, Dr. Bandar. Bismillah ar-Rahman ar-Rahim. Wassalatu wassalamu ala afdal anbiya wal mursaleen. نبينا محمد وعلى وصحبه وسلم. اللهم علمنا وانفعنا وانفعنا بما علمتنا وزدنا علما. It's my pleasure to be here with you today. I would like to thank the organizing committee for inviting me. So I'm going to talk about one of the most, you cannot challenge this actually in trauma practice in general, which is the emergency or resuscitative thoracotomy in general. The challenge usually in thoracic trauma is that not only when to operate on the patient or how to what kind of access do you choose to go and stop the bleeding or resuscitate the patient, etc. The point is, most of the thoracic injuries in general are hidden, and they are really challenging to diagnose and to identify. That's why there is the ATLS protocol, which standardized the practice of identifying the trauma in general. So you have to have a high index of suspicion, because it's not like, for example, like the abdomen, etc. And the thing is that, for example, when you're in the surgical practice, you will mention, oh, okay, there is a trauma patient, he's hypotensive, tachycardic, and the abdomen is rigid. You just go for laparotomy. You have to examine the patient thoroughly, initially identify the thoracic trauma, because there are some signs that, especially with the busy trauma suite, that you will not be able to identify, or, for example, listen by auscultation for decreased air entry or hyperresonance percussion in general, so you can identify this injury that might burden patient's life. So I just put this case. It's a 25-year-old young man who was a victim of high-speed collision, lost control, and hit a wall. Initially, when he came to ER, his blood pressure is 80/55, and the pulse was 125, with respiratory rate of 35. The point is, I put here this scenario just to tell you that this patient is mostly in hemorrhagic shock, and while you were doing your ATLS protocol, ABCDEs, he suddenly had a sudden cardiac arrest. My message here is very simple. If you are having any patient with witness cardiac arrest, okay, first of all, you have to go back and start your assessment again. But in regards to A, B, C, okay, immediately you have to intubate the patient. This is very important. You have to put bilateral chest tubes, and you have to do fast for the pericardium to look if there is any cardiac tamponade, and you can go later on for whatever maneuvers you will need to do to relieve this tamponade. So this is important, because in practice in general, with a busy team, with surgical teams, etc., they might miss these things, okay? So basically, these are very important standards, initial management of those patients with what we call witness cardiac arrest. I'll talk a little brief about thoracic trauma in general. These are the latest worldwide data that thoracic trauma accounts for up to 35% related deaths in the United States. And most of them, and most in the modern countries, motor vehicle collision is the most common cause of thoracic trauma in general, taking in consideration penetrating injuries, other than that, wars in general that can also cause penetrating injuries to the chest. This is an overview about the mortality. The problem of these thoracic injuries, if not identified, you might have a high mortality rate. But the latest data, most of the victims, they die at the scene because of, for example, aortic disruption, etc. So they will not be able even to reach the emergency department. 5% of them will die within an hour, and about 85% of them survive. Etiology, as we have mentioned already. Mechanisms, as you know, usually it's due to acceleration, deceleration injury, compressive injuries, penetrating injuries, and these differ usually between blunt and in the terms of blunt and penetrating injury, and what kind of difference strategies that we will use to intervene or do thoracotomy, etc., in those patients with trauma in general. This is a summary of the common thoracic injuries in general. As you can see, what we face usually in trauma, those patients who come with rib fractures, and most of them are managed conservatively when taking in consideration the pain control, incentive spirometer or chest physiotherapy, etc. And the list comes after that, like hemothorax, and most of them are drained by chest tube, flail chest, heart injuries, aortic injuries, what are very rare. Liver and diaphragm, usually those due to lower rib fractures that are covering these abdominal organs. The outcome of morbidity and mortality in general in thoracic injuries are mostly due to impairment of cardiac output, and most of these patients either that might have tension pneumothorax, okay, which should be decompressed immediately as a direct life-threatening injuries, also cardiac tamponade. These are cause impairment of cardiac output in general. Ventilatory insufficiencies like in lung contusions, etc., and impairment of gas exchange, the same. We have mentioned this, either we have blunt or penetrating injuries. The blunt trauma, the associated injuries that might be associated with are airway, tension pneumothorax, the cardiac tamponade, as we have mentioned, open pneumothorax, massive hemothorax, and flail chest. So as we have mentioned, the penetrating trauma in general, it has higher incidence in wars and or in crime cities in general, where there is a lot of gunshots, etc. Handguns in general population, as mentioned. Urban areas, they used to have the stab wounds. Management has basic airway, breathing, circulation, disability, and exposure. The goal of the management in general is to do a proper resuscitation for this patient, whether by giving blood as early as possible, or by doing specific maneuvers that will lead to picking up the vital signs of the patient and improvement of general improvement for the outcome. And the second most important thing, as we have mentioned, identifying the life-threatening pathologies in general, and sometimes understanding, if you have time to understand the mechanism of injury, for example, stab wound at the cardiac box, okay, you will put in mind that this patient might have a direct cardiac injury, might have a cardiac tamponade, I have to intervene immediately. Alarming signs in general: hypoxia, tachypnea, respiratory distress, tracheal deviation, and engorged neck veins. Engorged neck veins, especially in cardiac tamponade, where there is a poor cardiac output and there is stagnation of the blood, and this will cause the backflow to form the engorged neck veins in general. The initial step for any thoracic, if indicated for thoracic injuries, and this is the most common procedure that we are doing in trauma, which is the chest tube insertion or thoracostomy tube. 80% of thoracic trauma patients might need chest tube, and they will be managed according to that without any surgical intervention. The most important thing I'm always telling my junior staff, residents, specialists, medical students, please, whenever we put a chest tube or do any procedure, we have to respect the pain. So proper analgesia and local anesthesia is very crucial for a successful procedure and pain management post this procedure in general. I put this diagram just to show you how important anesthetizing the patient or putting a local anesthesia. Most of in practice, they put the local anesthesia in the skin and subcutaneous tissue. But for a successful chest tube insertion, we have to try our best to put it in the subpleural space. Okay, using the Seldinger technique, you are making a negative pressure while you are advancing the needle until you reach the pleural cavity, where you are going to, for example, withdraw air, blood, etc. Depends on the pathology, underlying pathology. Then after that, you'll start injecting. This is very important in successful. Apart from this, for those patients who will have witnessed cardiac arrest, at that time you don't have time to anesthetize the patient and put local anesthesia. So basically, you'll just need to go and stop and decompress the chest and then put the chest tube after that. So in such critical situation, there are some important exemptions. So emergency thoracotomy in general, we have either emergency thoracotomy that is done sometimes this is done in the scene or in the emergency room, most commonly, and the operating room. Okay, the goal of this procedure in general, either one of two things: either you had identified an underlying pathology, for example, a hemothorax, an ongoing hemothorax, let's say, and for example, if there is cardiac tamponade, etc., then you will go to do this emergency thoracotomy for purpose of repairing, etc. And there is the resuscitative thoracotomy. The resuscitative thoracotomy, for this, that you will need to do an anterolateral thoracotomy and to decompress the chest and try to do, for example, an aortic clamp to give time for our colleagues, the anesthesiologists, to resuscitate the patient and give proper medication. Also, for resuscitative thoracotomy, you can do cardiac massage, you can inject adrenaline, etc., in the muscle in general. Okay, so the common indication for doing emergency thoracotomy is witnessed cardiac arrest, and we are going to come back later on and show you and tell you when to operate on those patients in general. Hemodynamic instability, patients with chest tube draining about initial of 1.5 liter blood or an ongoing bleeding of 200 to 300 ml per hour. Other than this, direct cardiac box penetrating injuries, and whether there is a massive air leak where you are not able to ventilate or oxygenate the patient in the trauma bay or in the ICU later on. Rarely we use emergency thoracotomy for patients with blunt trauma, and there are some specifications for using it. So these are general indications for resuscitative thoracotomy, penetrating injury with pre-hospital cardiac arrest. We'll show a diagram in a while. Penetrating blunt injury with witnessed cardiac arrest. And if you are operating in the OR for any other pathology, like doing laparotomy for liver injuries, etc., and the patient has all of a sudden cardiac arrest, you don't go and do external compression, you just go and do left lateral thoracotomy, go do cross clamp and open the pericardium and deliver the heart and start doing cardiac massage. The objectives in general: relief of cardiac tamponade and immediate repair of cardiac injuries if present, cross-clamping of the aorta, as we have mentioned, open cardiac massage and defibrillation, and control of hemorrhage. One of the studies, this was done recently in 2004 in a Chinese institution, that they have found that most successful emergency thoracotomy are done whenever you are identifying a thoracic pathology, and most commonly, as I mentioned here in the paper, the cardiac tamponade. But this was around in less than a year experience, and they had about 33 patients. So I don't think that, but in general, we have to put in mind that those patients with identified thoracic injury, they have much more benefit, outcome, and survival from this procedure, because resuscitative thoracotomy in general, in most of the publications and worldwide, it is known that it has a high mortality in general, which reach up to 80 to 85%, and some of those might survive. And they found that it is whenever there is an identifying cause in general. So as you can see here, to summarize this, whether you are having a penetrating trauma or blunt trauma, it depends on the timing of presentation. Usually, if the penetrating trauma with loss of vital signs of less than 15 minutes, you can, yes, go for emergency thoracotomy or resuscitative thoracotomy and repair whatsoever you want to do. For the blunt trauma, as we told you, there is no clear significance of doing it, but the most of the literature mentioning that those blunt trauma who arrived with witness cardiac arrest or loss of vital signs within 5 minutes, you can go and do resuscitative thoracotomy or emergency thoracotomy in general, okay? This is the point. The cut point is for penetrating trauma less than 15 minutes and less than 5 minutes for blunt trauma. In general exposure, there are a lot of access for thoracic injuries, but if you are having a patient who is hemodynamically unstable, presenting to ER, penetrating, blunt, etc., the most important thing you do, or the most common procedure we are doing, is anterolateral thoracotomy, left anterolateral thoracotomy. The idea of left anterolateral thoracotomy that you can go and extend it to the contralateral side and do what we call the clamshell thoracotomy, so where you are going to have much better exposure, and you could go up to the apex of the lung and the apex of the pleural cavity in general, and you can manage promptly. You can, sometimes we use some patients, some surgeon might prefer to put the patient on cardiac pump, ECMO, etc. It can be also accessible, although very rare to be used. Sternotomy is used. Posterolateral, usually we use it if there is a subclavian injury and the patient is stable and you have time to go and operate. But anterolateral still is the standard of these procedures. Sternotomy also, if there is, although it's been discussed before, but still, and for any cardiac injuries, you can still go, or root of the aorta, you can still go through the anterolateral thoracotomy. So these are what you can see here. You can see in the left side the sternotomy, and this is the most common one we are using, the left anterolateral thoracotomy. We do resuscitative thoracotomy, and you can extend it to a clamshell, which is on the left side there. Trapdoor we are rarely using. And this is a very simplified picture where you can understand what do we do in resuscitative thoracotomy. So basically, or truly, this is the picture you are going to see through your left anterolateral thoracotomy. So basically, you can easily liberate the aorta from or you dissect the parietal pleura, so you can access the aorta and you do cross-clamping and give time for the anesthesia colleagues to do their resuscitation. Also, you can just go and do pericardiotomy just anterior to the phrenic nerve, and you can deliver the heart and start cardiac massage, inject medications, etc. And you can stop even through this, you can do primary cardiac repairs, etc., whenever needed. The last thing, I just put a few notes about REBOA, which is resuscitative endovascular balloon resuscitation in general. So the point of this can replace, but it's not used in most of the centers. The REBOA in general, it can give you the same principle of resuscitative thoracotomy, okay, where you can put your catheter and go into different zones. Zone 1 is between the subclavian and the celiac trunk. Zone 2 from the celiac to the renal. A renal goes to the bifurcation of the aorta. This is the zone 3. So basically, based on the site of the bleeding you are having, you can just use this procedure as a bridging to go and give time for our anesthesia colleague to do resuscitation until we go into the definitive procedures that need to stop the bleeding in general. So the thing is that, or the challenge we might face, that whenever we're having a patient that needs resuscitative thoracotomy in the ER, that most of the physicians that are facing the face in the beginning are either emergency physician or junior staff in general surgery. Okay, so sometimes emergency physician, I'm sure that they can do resuscitative thoracotomy in the emergency room, but the idea sometimes general surgeons, they are not able to do these things. There are some successful stories, but still very important. The point is, I'm mentioning this, it could be due to the lack of thoracic surgical training in general, or lack of cases, because we don't face thoracic traumas that need emergency thoracotomy most of the time. Okay, so we were discussing a lot of things of integrating the thoracic surgery rotation into the general surgery rotation, so the resident will be able to see more cases of thoracic surgery. They understand the anatomy, they understand the surgical access, how to do anterolateral thoracotomy, etc. But still, these things cannot be achieved until now. One of the things that I like today from this morning lecture is about the simulation. And I hope that if we can introduce this simulation in the surgical training, so where they can go and do thoracotomies and understand where are the landmarks and how to operate, and what to face when they access the thoracic cavity in general. So hopefully with the time of the improvement and the evolution of the simulation practice, this issue will be resolved, inshallah. So my take-home message for this lecture, it is very important to identify, or immediate identification of the life-threatening injuries. Understanding the mechanism sometimes is very crucial if you have time. We have to go through the trauma protocols in general, and we go systematic whenever the patient is deteriorating. So you go back from the beginning and you start your resuscitation. Mastering the anatomy is very important to deciding the proper exposure of your thoracotomy needed. And although of high mortality overall, still ED thoracotomy can save a patient's life. And my last important message, please control the pain, control the pain, control the pain. Thank you very much.